And all right, welcome everyone. Phew, that was exciting. Thank you all for being here. My name is Pete Van Leer. I'm with Policy Matters Ohio, and we are here today to hear from folks in Albuquerque and Durham about their community safety work. This webinar is hosted by Policy Matters Ohio, Ohio Families United Against for Political Action and Change, the Columbus Safety Collective, and Disability Rights Ohio. So we're all here looking at how we can support and advocate for safer communities and community crisis response, community emergency response in our cities and around the state of Ohio. So with that, we've started recording, and I'm going to pass it off to Leah Beavis, and you can introduce yourself, and she's going to be facilitating. Then we're going to have time for Q&A, and then we're going to wrap it up by 1:30 at the latest. So thank you. Leah, go ahead.
Awesome. Thanks. Okay, so as everybody probably is aware, we have folks who are here from Durham, as well as folks who are here from Albuquerque. And those two cities are really exciting to think about because they both have these really interesting, actually multi-tiered sort of alternative response systems with non-police response, as well as I think in both cases, maybe they can correct me if I'm wrong, co-responder systems, like a sort of nested set of response types. And so we thought that we would start with one participant from both Durham and Albuquerque, just kind of giving the origin story of the non-police response component of their alternative crisis system. And maybe we can start with Ryan from Durham, and then we'll move to whoever wants to talk about that story from Albuquerque. Thanks.
Great. Thanks for the invitation to be here. My name is Ryan Smith. I'm director of the Community Safety Department, and I've been the director of this department since it was created a little over 3 years ago. So our origin story really begins, in some ways it begins before the murder of George Floyd. So I think in the city of Durham, we had a number of nonprofit and advocacy groups who had been organizing for years. They had put together, probably a year before the murder of George Floyd, a set of recommendations for our city council, calling for things like investment in alternative responses, at that time pointing to Eugene, Oregon, calling for the creation of a community task force that would look more broadly at our criminal justice systems. So all that was in the air, things that council was considering. Following the murder of George Floyd, our city manager at the time, Tom Bonfield, I think the story in Durham was similar to many cities across the country where folks were demanding a lot of change. They were painting signs like defund in front of the police department and fund this in front of Health and Human Services, a bunch of actions like that. Our city manager decided to partner with a group called RTI International, which is based here locally in North Carolina, to really understand why people call 911. And so that group looked at 3 years of 911 call data to understand why people call, what are the outcomes of those calls, how many involve use of force, a whole range of things. And they also started to look across the country at how other cities were beginning to think about different responses for some of these calls. That was presented to City Council about 6 months after the project started. And the big takeaway from that data, which is all still publicly available and we're happy to share, is people call 911 for a whole range of reasons. Some of those we have 3 branches typically to send to these calls, and for fire when your house is on fire, and cardiac arrest EMS. But a lot of other calls have traditionally fallen in the law enforcement bucket, and it was pretty clear from our data that violent crime was a very, very small part of that bucket, and that people were calling for a whole wide range of other needs for which it wasn't clear that law enforcement was the most appropriate response to those calls. That was presented to the city manager. She took that, looked at some of the things happening across the country, and decided to create a new public safety department. So the community safety department that I run is a standalone city department apart from law enforcement. We are part of how we talk about it here as our public safety portfolio that includes fire, our emergency call center, police department, and community safety. And all 4 of those departments have a common report up to a deputy city manager. So that's how we're structured. Our department was created, and in our first year, we had about 13 staff, and all of them were vacant. So I was appointed to be director, and we took our first year of our origin story is really planning. And Albuquerque is a part of our origin story because they were out in front. So part of our planning was reaching out to other cities, much like you were doing, and learning about how they were approaching the work. I have found other cities to be incredibly generous with their data, with their policies, which all helped us in our planning process to tell the story of what this was looking like in other communities. Because, origin story is, I think a similar theme in every city's origin story are concerns around safety. And certainly locally, we had to work with public safety and other community leaders to answer questions people had about, is this safe to do? Because you're talking about sending folks that you used to send law enforcement to. And so, getting data from other cities like Albuquerque and Denver and San Francisco helped us, I think, build some early confidence that we could do this. So, learning from other cities, looking at our own data, we took a multi-agency approach. So we decided to do this work by creating space at the table for law enforcement, fire, emergency communications, local behavioral health providers. That table wasn't a space of vetting where everyone had to agree with what we wanted to do, but it was a space of conversation where we could share what we were interested in. We could create a space where we could learn together. We could understand the concerns of partners and demonstrate the good faith approaches we were taking to take those concerns seriously. And that, I think, really helped our work. And then we took a lot of time throughout that year to, again, continue to build trust with the community, to understand the values that community members wanted in this, the kinds of training they wanted responders, the types of lived experience they hoped would be in our response, the type of calls they hoped we would show up to. All of those things went into the development of what then became HEART about a little less than a year after our department was created. And just quickly, I know we'll talk about this. So HEART, through all that work, we created HEART, and HEART is four things. It puts mental health professionals in our 911 call center to support remote, like responding over the phone, triaging calls in 911. We have a complete non-police response. So we're sending a 3-person team of a clinician, like a social worker, a peer support specialist, and an EMT to calls we used to send law enforcement to, and we'll talk about that more. We have co-response, which here is a joint departmental response. So the police department puts a CIT trained officer, pairs that with a clinician in our department, and they ride together to higher acuity calls where weapons or violence may be involved. And then we have a whole dedicated team we call care navigation that follows up after a 911 call to continue to support someone for a month after that call and connecting up to existing services. So that's our origin story in a nutshell.
Awesome. Who wants to talk a little bit about the beginnings of the program in Albuquerque?
Good morning, everybody. My name is Walter Adams. I'm the Deputy Director of Field Operations here at Albuquerque Community Safety. And our origins are a little bit similar. They parallel in a lot of ways. ACS was created, and what we did was pretty much level political will and put it into action. ACS was created also as a result, of community calls for action within our own community and, after the George Floyd murder. So coupled with our Mayor Tim Keller's vision of what an alternative response would look like, City Council support, and our police chief buy-in at the time, and it continues today, that's how ACS was launched. In ways, we in June of 2020, ACS was launched as an initiative, and what this department would look like. In between June and January of 2022, they began the community engagement process, and which was huge for us, similar to Durham, is like we wanted the community we wanted to know what the community looked like or wanted in a response from someone that was an alternative response that wasn't your typical police or fire response or EMS response, but specializing in mental health. So community engagement and their feedback was absolutely huge in creating our department. And then between January and August of 2021, there was the planning and implementation phase. I was one of the first 5 responders that started. It was 5 responders, 5 admin staff, that made up the whole all of Albuquerque community safety. So I was fortunate enough to be one of those first responders, and then we launched in September 2021 and diverted our first 911 call. So we are a third branch to public safety, fully integrated in our public safety system. It's police, fire and EMS, and ACS. So now when you call 911, you have the option of the three, and it's not an option, but based on the criteria that comes into the call, where that call is diverted to and that appropriate response. So we diverted our first call in September 2021. We just celebrated in August of 2024 our first year where we launched 24/7 operations. And at the time we had responded to over 80,000 calls for service. Right now we probably surpassed over 87,000 calls for service at our most recent update of data. And then in February 2024, we went live with on police dispatch through the 911. So when we originated, it was kind of, integrating a new department into the overall public safety system. Where does ACS fall in? Where does this alternative response fall in? They're going unarmed. What does it look like? Who's dispatching them? So when we first launched, we launched under fire dispatch. And what we noticed through the first couple of years was that ACS was taking some of the higher acuity mental health calls, still higher acuity calls that still ACS was appropriate for, but for safety reasons, we started getting dispatched by our APD, and we launched that in February 2024. So we do have different levels of responders. We also do have a co-response model, which is a clinician that's part of ACS, riding with the sworn CIT trained police officer, and they go to the higher acuity calls. We also have our community responder, which is like an entry-level position, and they take lower acuity calls that are designated for Albuquerque community safety. So they're going out to our unsheltered calls, wellness checks at like bus stops, and then they ride in pairs, and they'll go out to calls. Then we have our behavioral health calls our behavioral health responders that will take all of the calls that are fit into the criteria of a call for ACS. So they're going to individuals experiencing behavioral health crises, individuals having suicidal ideations, welfare checks, wellness checks. Every call that we have on our call types, behavioral health responders can respond to those. We also have our street outreach and resource coordinators who concentrate on unsheltered individual calls, encampments, and we also just launched about a year ago, we launched navigators. So now they're following these people for up to 90 days, sometimes longer, identifying and trying to guide them through the housing process. In that as well, we partnered with UNM, the University of New Mexico hospitals. And what we recently launched within the year is mobile medicine. So now it's a street medicine team that has a doctor, psychiatrist, and we go out into the community doing proactive outreach with them attached to us, so they're able to identify quickly and address any medical or mental health needs on site. So we found successes in that, and we've also, because we get a lot of unsheltered calls, we've started looking at where we find those pieces, and integrated what we call connect to cares. So we go out, provide outreach, and then we have all sites, including the Department of Health, on site with us, other service providers that were able to connect individuals immediately in there. Also, we have our violence intervention program. So we have our school-based violence intervention program, our violence intervention program, our opiate education and prevention program, all within and under the ACS umbrella, doing different things. So we've grown over the last 3 years. We've grown tremendously, but that's kind of how we started.
Awesome. So the next thing that we wanted to talk about, you sort of started, so I almost want to say, let's have you or somebody else from ACS continue. So you gave us this great picture of the basket of programs that you guys have. You have a co-response, which is the clinicians paired with officers. You have the non-police response, which you started with, also community responders, street outreach and resource coordinators. Then you have navigators who are helping people go through the housing process or maybe other processes too. That includes a mobile medicine component, which is really cool. And you have a violence interruption program. So that's a lot of different layers to your alternative response system, which is just so cool. I think the thing that would be really helpful for places like Columbus that are thinking about how to set this up is if you could give us first a little bit more detail on exactly what types of 911 calls each component is responding to. So sort of like that rubric where dispatchers are saying like, you go to here, but like you go to here, like what is that rubric? What are the calls that each group responds to? And then maybe if there's sort of an evolution story of like why this group popped up, like was violence interruption there already and then it got put under ACS, or was it added subsequently? It sounds like the mobile medicine component was added later. Were the navigators coming from another nonprofit that was already working, or was it an entirely new thing? So both, what exactly is each group doing in terms of like the call type, and how did you get to creating that layer? So maybe let's start with you, and then we'll come back to Durham to talk about the same.
Okay, that's a great question. So the first people that we hired under ACS was our clinicians, because there was something already in place. Before, our clinicians were contracted through nonprofit, and they would directly respond with an APD officer or police officer. At the time they came under ACS, they were the first hire. It was an easy transition for that to happen. And then the first 5 responders were behavioral health responders. So looking at the call types, behavioral health responders can respond to any call within our matrix of calls. And so that was hire those first so that they can respond to any call. But one thing to remember is no one knew what this was going to look like. So initially, when we first started the first month or two, even though that there was calls qualified for us to take, they weren't being sent for us for a number of factors. So a lot of our responses in the very beginning were all proactive responses. You know, us just going into the community to those high need areas and just identifying calls that were within our matrix. So again, behavioral health calls, suicidal ideation calls, you know, just checking on people that were out in the streets.
So to be clear, when you say behavioral health, you're talking about mental health related calls, suicide related calls, perhaps also substance related or overdose calls as well?
Correct. So that's
great.
When I say our behavioral health responders in some go to mid to low acuity behavioral health calls, and then they can run the gauntlet of everything else that we respond to.
And when you say mid to low acuity, just for all the listeners, I think you mean something related to violence or weapons, correct?
So we can take any call that's non-medical, non-violent, non-enforcement. So it's any call that falls within that call type that would come through 911.
Awesome, thanks. All right.
And then we integrated our community responders was the next thing that we integrated. And that was kind of created to provide an entry level and a pathway to later become either a behavioral health responder, mobile crisis clinician. But it was a way to increase staff and also a way to meet some of those needs when our call volume started to increase. So this was always the vision since the beginning. It was just at the beginning, it was the funding piece of it and how many people we can bring on. And then actually going through the hiring process of all that. So behavioral health responders were first, community responders were second, and then street outreach were third. And those were all within a matter of like 4 to 5 months when we brought on our first responders. So that's all of our responder piece of it. Now, when we talk about violence prevention intervention, there was a violence intervention prevention program under another department. And at the time when it was under another department, there was only one interventionist. And so if it was just a perfect match where they could come under ACS, so we absorbed that position. and then grew the violence prevention intervention to what it is today. So that's where it started with the violence intervention. They go out and provide custom notifications. They go try to interrupt the cycles of violence. But in that, we found room to add, school-based violence intervention program. We found room to add the opiate education prevention specialists, and those are all peer-led specialists that we were able to grow that side of the department on it.
And then just to be totally clear, so the behavioral health responders are responding, as you said, to sort of mental health and substance related calls. Community responders and street outreach, I can kind of guess, but can you tell us exactly what type of calls each of them respond to?
So I can run down the whole list. So our call types are, and they're coded like this. So it's behavioral health, suicidal ideation, welfare check, wellness check. And then there's disturbances, suspicious people. Again, everything does it meet that criteria of the violence and everything else. So So what we did was, another piece I didn't mention is we do have triage specialists. And those triage specialists, what we found was, because we were doing a lot of proactive the first couple of months, we embedded one of our behavioral health responders up at the emergency communications center where 911 was coming from. So now that person was looking at every call that was coming in through 911 and that was sitting, for a police response or EMS response or our response, and able to work with the dispatchers and the call takers to now divert that to ACS because it fit our criteria. So they served as a type of liaison to provide that guidance and support. And if they had questions, hey, is this a ACS call? They were able to provide the guidance there. So what we saw then, about 2-3 months in, was our calls that we were taking started coming in that we were being dispatched to just skyrocketed, right? That was a pivotal point for us where we started taking and started providing education in that. And out of that, about 2 years later, we created an actual position that runs 24 hours that just does that, and we call them our triage specialists. So what we did though is in our transition to our police dispatch was, and we had it before, was we have a matrix, and the matrix pretty much outlines that, mid to low acute, what that call looks like. For example, I'll give you an example, is a welfare check. What defines a welfare check? It's someone, for us, it's, I know this person, I haven't seen them in days. Can you go check on them, right? It's our welfare checks are coded as someone that's known to the individual that needs to be checked on. Our wellness checks are maybe a passerby, someone that the person is not directly familiar with, but wants that individual checked on. So again, what we did in that matrix was outline specifically what calls behavioral health responders could take, which is all of them. And then we also put there what community responders can take. So they take the lower acuity, the non-criminal calls. So they're going to needle pickups. They're going to some wellness check as long as it's not an identified behavioral health need. That's what community responders are going to, and our unsheltered, but it's clearly marked in that matrix. Well, another thing that we did when we were under AFR dispatch, we didn't have a true prioritization system. It was, we had one internally and we knew, prioritize this call over this call. But it was never a true, like, we're sending you to this because it's a higher priority. When we transitioned over to our police dispatch, we were able to incorporate that. And one of the things that we incorporated in that was also prioritizing officer calls for multiple reasons, right? One reason is sometimes when the call's taken, it might be of a higher acuity call, but when the officer gets there, it might be an identified need that was not as high acute, and that's a better response from ACS. So if the officer remains on scene, we prioritize their calls higher so we can get out there, relieve the officer, and take over that call as soon as possible. So we did that piece and prioritized that call. And then when we went to the true prioritization system, now we are dispatched by the priority and the level and the acuity of the call.
That makes so much sense. That's super helpful. Thanks. That's awesome. All right, Ryan, can you tell us sort of similarly about both the types of calls that each of your aspects is responding to, and maybe how you evolved to thinking that was the optimal system?
Yeah. So I'll walk through three of the programs again. So we started with all of these in our first year. The one we did last was co-response. That was about 3 months apart. But in the same week, we started crisis call diversion, community response teams, and care navigation. So crisis call diversion, just as a reminder, this is putting a licensed clinical social worker into our 911 call center, and they are there to respond to, they can divert sometimes any first person response, are able to talk to a person, assess their needs, connect them to other community-based resources. Sometimes someone calls 911 just for someone to talk to her because they don't know where else to turn or what other resources are out there. Sometimes they are supporting the caller while we're sending other first responders on scene. Suicide threat, maybe with a weapon. We're still immediately dispatching first responders, but the social worker can remain on the phone and help de-escalate the situation, gather additional information. So those are some. They also do follow-up calls. They'll call and check back in on people. They are responding to calls that get coded mental health crisis or suicide threat, and it needs to be a call where it is the person themselves who is experiencing the crisis, or they are with the other, with the person, because they need to be able to talk to the person, or it's someone. It might be someone calling about a family member, and they're talking to that family member who knows the person well. It doesn't work well with third-party callers if you're calling about someone that you see but you don't know, right? The social worker can't really help over the phone in that situation. The second thing is community response teams. These are first responders dispatched through 911, just like any other first responder. They're going to calls that used to be dispatched to police that now we don't dispatch police to if we have one of these units available. Again, it's a 3-person team. They respond typically in a minivan. They follow all traffic laws, so they're not a lights and siren response. They carry a ton of crisis supplies with them, and they transport people to a whole range of places, from to a 24/7 recovery and response center, to the hospital if it doesn't need an ambulance, to shelters, to someone else's home if they can confirm that is actual residence where the person is welcome. Those are the things that they do. These are the calls that they go to: nonviolent mental health crisis, suicide threat, trespass. This is how they're coded in our system. Trespass is, we don't have a call for persons who are unsheltered. It's all going to fall under trespass. Intoxicated person, so long as it doesn't escalate to needing an ambulance or an EMS, it's not a medical protocol. Panhandling calls coded as nuisance, indecency, prostitution, and then urgent and non-urgent welfare check. The next thing is co-response. Again, we have a clinician paired with a CIT trained officer. They go to these calls: mental health crisis where there's violence or a weapon, attempted suicide, trespass with a weapon, intoxicated person with a weapon, custody issue, panhandling or nuisance with a weapon. You get it. So weapon on these other things. Physical disturbance, verbal disturbance, disturbance with weapon, harassment with weapon, threat with weapon, reckless activity, abuse, threat, domestic violence, and domestic violence with weapon, calls coded drugs, and involuntary commitment. This has been our high level criteria for how calls are routed, and it has held constant over the last 2.5 years of operation. This is where we started. I would say we haven't contemplated moving anything from our community response to co-response. We are thinking about a couple of things that we might over time move the other direction that are currently co-response toward community response. Ones that I would name that we're looking at are things like verbal disturbance. The problem with drugs is drugs for us is like one large call nature, and it involves a bunch of different things, some of which could be really appropriate for community response, but some are not. It involves everything from like someone who is trafficking in a large amount of drugs to someone who just a neighbor might call because they suspect someone is, I don't know, smoking pot in their car. So there's a whole range of things get covered because of the broadness of that range. We started with co-response, but I think we want to explore how we could divide that call nature up, because a lot of those calls really would be appropriate for community response team. So those are the call natures, just in terms of how the program has evolved. So when we started again, we had 23 total staff. 20 of those were city staff, and we had a federal grant that added 3. 17 of those positions were first responders when we started, and that allowed us to do, I think, 3 community response teams, 3 co-response units, a few people dedicated to care navigation, and 1 person who we put in our crisis call diversion program. When we started, we made a decision to not launch citywide. We only covered a third of the city, and we didn't cover those like 24 hours a day. In fact, we are still today, 2.5 years later, not yet 24/7. We operated in a third of the city for the first year. We chose that looking at data and choosing areas of high volume for eligible calls. After a year, the manager and council assessed where we were and decided to increase our staffing 150% so that we're now a 50+ person department. And that was enabled us to go citywide 12 to 15 hours a day. And that's where we stand today across those programs. So I talked about how our service area evolved. We integrated from 911 right from the start. And I would, to me, that is a great decision and one that I would recommend any city to consider. I think it's really important to start with 911. I think one thing that we'll talk about is what are the ways you can get to your units. I think 911 is a system that everyone knows and most people are going to use, and it's an important place to start. And we developed a really strong partnership with our emergency communications center, fully integrated in that from the start. That really helped with our data. It helps with safety. It helps with a whole range of other things. And it took time. That it probably took us 3 or 4 months of just someone with a lot of skill focusing on making sure that could happen. And we didn't start until we could do that. And then I just want to go back and stress, we made the decision early on to hire internally, just like Albuquerque. That's an important decision point when folks are considering this work. I think there are trade-offs either way, but we feel really good 2.5 years later with the decision to develop that capacity in-house. And I'm happy to answer questions that folks have about that toward the end. The only 2 things. Oh, go ahead.
There's about that. What you mean there is that you are like the clinicians are being paid by their employees of the city.
They're full employees of the city. We're not contracting out the work. So our department doesn't manage a contract where a third party, say a nonprofit behavioral health provider, is actually hiring the folks and doing the work, and we're managing the contract. All the staff are our staff. They're full city employees in our department, just like, say, law enforcement officers are employees of the Durham Police Department. And I think that's true. I'm certain that's true of Albuquerque as well. But that's not necessarily the case across the country. But those are important decision points. We, in our work, are working to launch 2 new kinds of units. So we're working on piloting an involuntary commitment unit. So this is one of the kinds of calls that co-response goes to. But we want a dedicated unit. We want to, and this is partly particular to North Carolina. I'm not sure how it works where you're at, but here anyone can go to the magistrate and get a police custody order if they provide enough evidence to the magistrate, where police have to go and take that person to the hospital to be examined. It's very common when they get to the hospital, they're not meeting the criteria. And that's, unnecessary trauma, unnecessary time to forcibly transport someone. So this unit is going to have a certified first examiner by the state on it that will allow us to move that first exam from a hospital setting out into the community, where we hope we can have better outcomes, avoid unnecessary transports, things like that. And the second thing that we're developing is we have a new dedicated, we call it a familiar neighbors unit. And they are focusing on a small number of folks who we interact with a lot. And instead of care navigation, which for us has typically a 30-day limit, they can work with someone for up to 30 days. Familiar neighbors unit has no limit. They can stay with someone and they're focused on being out in the community, proactively working with a small group of neighbors who are getting 911 calls on them or calling 911 a lot, to see if we can reduce the number of public safety interactions by better addressing some of the unmet, often complex needs. So that's another unit. And again, these units have developed over time in response to what we feel are gaps or a need for greater specialization. I'll pause there.
Thanks. That's super helpful. I'm really interested in this involuntary commitment unit. So maybe I'll come back in the question and answer to have a follow-up question on that, and also for Albuquerque about how they deal with involuntary commitment. But I'll leave it for now. Maybe there's someone else chomping at the bit to ask that question when we get to that part. The thing I want to have you guys address next is sort of a 2-part question, and they're informed by our experience here in Columbus. So when we're thinking about sort of the precursors to setting up these programs, like the political will, the relationships between different branches of government, like who's working with who to get this going, it seems like the relationship with law enforcement is really important. And so we'd like to hear you guys address briefly sort of what the relationship with law enforcement was at the start, like were they on board, were they not? If they were, how did you get them on board? And maybe how that evolved, like were they, questionable, but over time they liked it better, And then another question that I'm just throwing in now, to be honest, because I think it's really important right now in Columbus as we're thinking about this, is did your city do any kind of outsourced exploration of what models, like you spoke about talking to other cities, but Columbus, to be straightforward, Columbus has an RFP out and they hired an external party to do a kind of assessment of our current types of alternative response and to think about non-police response and how these things would sit in. And so we're paying a lot of money to this group that's going to do this sort of large scale multi-month step. And that's the first step before they move into actually setting up a non-police crisis response. And so I'm wondering, like, did your guys' cities do something similar? How much money did that cost? How much time did it take? And was it really useful? Like, was it a critical component of starting the program? Let's go back to ACS, Walter, or anyone else from ACS on those 2 points.
So relationship with APD, again, we had buy-in from our police chief into this program. I mean, we were at a time where, they were talking about the defund the police and this, that, and the other, but also there was a time where it was taking officers a lot of time to get to these lower priority calls. So ACS being available for some of these lower acuity calls, specifically in mental health. And I'll just say this is we were under a consent decree when ACS was created, and we're currently still under a consent decree. So we had buy-in from the police chief. That was huge. I think the biggest piece of that is you just don't need buy-in from the chief. You need buy-in down the chain. You know what I mean? So I remember going out to calls, and it's just kind of like, got to remember is, again, there's only a couple responses in the way you respond to calls, right? And I remember going out to calls and like some of those field officers just saying like, what are you guys gonna do? Like, how are you guys gonna solve the problem? Like, we don't understand that, but we worked and we showed, you know what I mean? Not only with that, but with dispatch, I think it's evident that there was hesitation to send us calls again because of the systems that were in place already. But it was taking us going and responding to those calls and providing those outcomes and, showing, all of our public safety partners, that there is a way to kind of respond differently than what's, we're all used to. That's what it took for us. So it was little by little building those relationships with those field officers. Hey, if you come across this again, give us a call. Hey, you can call us out. We started going in and we present at every new academy for our police department. So we're presenting on what ACS can do and the way we respond to calls. During the academy, when police officers are in the academy, we're presenting at every crisis intervention training that they hold for all the police officers. So it was a slow process, but it was also getting the buy-in from them, not only from, the higher leadership, but also those field responders now. And I will say we've seen in the last 3 years a huge transition in that. And like officers are just calling us out left and right. Hey, can you come for this? Hey, come for that. But again, it's that trust, not only our police department, but also our fire department, because they used to take some of the calls that we're taking as well. So I think that piece in regards to like outsourcing and seeing how other programs run, there wasn't a lot. You know what I mean? When we started Albuquerque Community Safety, like there wasn't a lot to kind of lean on and towards. I think one of the biggest one was Cahoots in Eugene, Oregon. But it was kind of just building on the ground up. Is like we learn every day, like from Durham, you know what I mean? Like we the navigation piece and the follow-up piece and all of that is like I think right now we're just learning from each other. There's not like when you hear about the alternative responses, like there's different models in different cities. Some are run by nonprofits. Some are, within the government. Some are standalone. Some are part of another department. There's just so much going on out there that we learn every single day. We learn in conversations like this. It's like, oh, maybe we should go try that. It's so new and so fresh. Like the sky's the limit. I'm just gonna say is the sky's the limit on the potential response that we're evolving every single day. And I mean that literally. Is like we go to a call and it was like, how can we have addressed that call differently? You know what I mean? I mean, officer involved shootings. We see an officer involved shooting and we're analyzing that call as could we have responded to that call in any point? Could we have responded to that differently, right? How do we work with that individual in the past and what did we do in the past? So, almost every day something comes up to say is like, how can we expand and how do we do it? I think the biggest problem is we want to do it faster than we can actually do it just because, we want to solve all the world's problems right away. And it's kind of like we have to take a deep breath and say, like, how do we get to that point?
That's so helpful. It's really cool to hear you talk about how critical it is to have sort of communication with all these different groups that are trying things in this cutting edge way constantly. Do you know if in Albuquerque they did this sort of like a study, a sort of internal looking study on crisis response prior to starting up ACS, or did they really just lean on the process that you're talking about, sort of like reaching out to other cities, seeing what other cities are doing, and then like just trial and error?
I think there was research not specific to any. I know our leadership had reached out to Eugene, Oregon, and I think at the
Okay.
time that there was like costs associated with this and costs that we didn't have, what I mean, the
Yeah.
money to do it. And but I think that there was research involved in it, but a lot of this was community driven. I remember me being one of the first five responders and going in to training and us partnering with some of the people that would be affected by our response. What does an ACS responder look like to you? The community driven approach was a big driver in the way we established ACS and what that response would look like. Everything down from the clothes that we're wearing, what I mean, to the vehicles that we're driving. All the vehicles that we drive, they don't look like police vehicles. We have emergency lights and everything, but there's not any on the top. They're different colors. The unit that we drive, it's a Ford Escape. It doesn't look anything like a police vehicle, right? So it was very strategic in the manner that it was done, but all of it pretty much, and to this day, was all community driven.
That's awesome. Thank you. So then let me throw this back to Ryan, but add in the component that Walter. So, maybe a little bit about the relationships with police and how that evolved, if there was any sort of internal looking study as well as outward looking study, and also how community was community voice and community preferences were accounted for. Thanks.
Everything Walter said really resonated with me. I think the really biggest difference in our story is our start point was not we had support from the chief of police or from law enforcement. When our department was created, I think that it was created with a lot of support from city council and with the manager. Law enforcement was largely kept out of that decision, and our police chief left after that decision, and probably for many other reasons. I don't know how that factored into it, but law enforcement felt a whole range of things about the existence of the department, and most of those probably were not good in the beginning, from skepticism to this is either going to someone's going to lose their life as a result of this. This is unsafe. This is a threat to my job. I'm going to lose my job. A whole range of things factored into that. So when I came into the position, one of the things that was important to me was I believe that we could do this work in a way that was with integrity for the kind of vision and the hope for what this work and why this work was being created, but in a way that was also had support from the police chief, had support from patrol officers, and that they saw value in this work. So part of how we went about that, of kind of moving from there to where we are today, which is, I think, much closer to where Albuquerque is. First, it started with the top. I made a commitment that we had a new police chief came in. That police chief was hired knowing that we were going to exist and supportive of that. And so that, in some ways that we did and didn't start with support at the top. But we met regularly. We had regular one-on-one meetings to talk about this work, to create a trusting relationship. where we could disagree on things and have good conversations. And that was really critical. But to Walter's point, absolutely. At the end of the day, it's about everything up and down the chain. But I do think starting with, if you can get strong support among the leaders of the various things, I think that helps, especially in organizations that can be pretty hierarchical. So, we got strong support and worked to build that relationship with the chief of police. Before we launched, we spent time on Saturday mornings going early and meeting with every single officer when they would have like these Saturday kind of meetings and trainings to talk about the work, just to create an open space for them to express all their skepticism and deep questions. I don't think we won people over in that. I think it was an important time of communicating, of coming and sharing what we were thinking about doing, of hearing their concerns. The biggest thing for us is, I think two things really helped us. Officers would name that hated change. They were very skeptical. The only way that I think you can really build support among patrol officers is to actually do the work. And so we did the work, but one of the decisions we made is we did the work on the same the same radio channel that all of our police officers were on. We did that for practical reasons, but it had an unintended consequence that officers got to hear us, take calls, know they weren't coming to our rescue every time, and appreciate that that was a call they didn't have to go to. Because similar to what Walter shared, we had 20+% staffing shortages in DPD. They were working overtime. Being able to relieve call volume was good. And also they began to have confidence when they would hear our responders take calls like other first responders, show up and not press the emergency activation button, asking for, all the officers to come to their rescue. Those things really, really made a difference. And I would have officers come up to me when I was presenting in the community and say, hey, I was really skeptical, but I have to admit I was wrong. And thank you for, the work your team is doing. The other thing that we did, and this is more culture building, is early on, we were hearing from some officers, oh, you all think you're the only ones who provide compassionate care. And so one of the decisions we made is asking our responders when they're out in the community, when they see other first responders, including law enforcement, do something that they think is an example of compassionate care, to send an email to me with the officer's name and a brief description. And I would share that with the chief of police, and then we would include it in that person's kind of personnel file. And those kudos emails, we had folks up and down the chain say, hey, we really appreciate that, because I think it showed that we were capable of seeing the whole of the thing. And it also, when we did have something that might be constructive criticism, they were more likely to be received, because we were capable of showing that we see the good work and that we see ourselves as part of a broader team. So those things, doing the work, trying to position ourselves consistently. We never talk about defunding the police. We always talk about we've been consistent in messaging about our work as being part of the broader public safety team, making sure we're able to send the most appropriate response based on the needs of someone. Those things over time have really changed it. And I'll just say a few things why I know that. One, we're seeing an increased number of calls that police are requesting HART. But we worked with a group that did a survey of officers about their perception of HART before it launched, and then about a year and a half after. And we saw just a couple stats I'm going to share. So the percentage of respondents, these are officers, reporting HART to be very or moderately helpful in addressing 911 calls, increased from 37% to over 66% now. The number of officers who said that HART was not at all safe decreased from 47% to 27%. So there are still officers who think that what we're doing is not at all safe, but it is significantly decreased. And if you had told me that, I would have thought that it would take much longer to see this type of change. We see, over, in terms of officers who think that we are moderately to extremely helpful on calls involving homelessness, 46%, calls involving frequent 911 callers, 51%. So in a range of things we have seen in real measurable ways, the perception of HART and the police chief herself has shared in recent meetings, officers are saying, when is HART going to be 24/7? And I think those are all good signs. So it's an absolutely critical relationship. Everyone should do this work believing that you can do it with integrity and in a way that doesn't alienate law enforcement and kind of can build a stronger collaboration. And I think we've been able to do that here. The second question, can you remind me the second piece of it?
The other two pieces were, how did community voice come into the planning?
Yeah.
And also, did did the city do any kind of internal looking assessment of their own
Yeah,
staff, or was
I'll
it
answer
external?
the last one first. So yes and no. So before a department was created, and about the first 6 months, the city partnered with RTI International, and they did this analysis of 911 calls, and they did this kind of very high level survey of a couple of examples out there. That really shaped the manager's decision to create a department. But what HEART would look like was entirely driven by our internal work as a department and learning from other cities. And we held multiple town halls with community members that were interactive in nature, like helping kind of create spaces of co-creation and like what types of values, how do you want our responders to appear? So we wear mint green t-shirts, we drive minivans. All these things were shaped by workshops in communities, town halls. And then we learned a lot from Albuquerque and San Francisco and Denver and our crisis call diversion from Austin and Houston. So we did a lot of that work too, and that was internally driven. We didn't have outside help for that, but by our staff. And then I guess to answer both questions there. So yes, community input was an important piece that shaped it. We actually have a report on our website that we can share out with you all that summarizes, the different things that we learned and incorporated from our engagement in community into the design of HEART. So I'm happy to share that.
Awesome. Thanks. All right. I have more questions, but I will stop there. And I think let's turn this over to questions from our listeners. So for those who don't know, they can go to the Q&A. And to be honest, I don't even know what it looks like to you guys, but there's a way to enter your questions in the Q&A. If you can't figure it out, feel free to put it in the chat also. And we have two questions already. So let me ask the first one already by Corey Schlafer, I think. She says she's curious how and if each of the programs interact with 988, and specifically are high acuity 988 calls routed to you guys, or are they, handled by a totally separate system? And whoever wants to jump in can.
I'm happy to jump first. So we
sure.
aren't really integrated with 988 yet. 988 is about as old as we are. We have a single call center for the entire state, and we've been talking with the state Health and Human Services about that. I think it will happen. 988 can, for high acuity calls that come into 988, they will route them to 911. That doesn't happen very often. If it does and HEART's available, then it would get to us. But there's no direct way for people to call 988 to directly have 988 dispatch a HEART unit, but we're actively in talks about that. But really, the only way today you can get to us is through 911.
Got it. But 98, sorry, you may have said this, but 98 exists, but just totally separately.
988 exists totally separate with one call center serving the entire state, but we're working on figuring out how someone could call 988 and they could deploy HEART if it's within Durham County. So
thank you.
And ours is similar. We do have a 988, but it's completely separate. And we will take calls from 988, but they go through 911. I think one of the concerns for us when it was doing is the actual call taking piece of it, and the safety for our responders when it was coming in, right? Because what questions are being asked and how is that going to be dispatched in the sense of it. So those are conversations we've had in the past as well, of what that looks like.
That's helpful. All right, so then the next question from Rosie, I'm not sure how to say this last name, but Palf maybe, says that like Albuquerque, Cleveland is under a consent decree. And I thought I was thinking even when you first mentioned the consent decree that we should maybe define that for people. So my understanding is that consent decree is a sort of a court enforced settlement that came out of settlement where there's an agreement to change certain practices that came out of some sort of a lawsuit often. Do one of you guys want to make that more specific for me?
Yeah, so that the specific question is like, yes, we were under a consent decree. There was several things that had happened that one of the things, part of that consent decree was, training officers to be more involved in crisis intervention training, right? Approaching individuals with mental health crises and stuff like that. We do have an MRAC committee, which is the Mental Health and Response and Advisory Committee. I'm looking out this question here. And our MRAC is involved. We have subcommittees to that MRAC for policy review, training. what that training looks like. And they do make recommendations to us. We are also part of that MRAC committee. So we sit on that committee and we have monthly meetings when it comes to that. So I will say with the piece of the consent decree, the creation of Albuquerque Community Safety and the work that Albuquerque Community Safety has done to this point has helped with advancing compliance with the consent decree. So I don't think that that was the original. I don't know. I'm not gonna say, but if that was the original intention, but like the Department of Justice under that consent decree has come back and publicly stated like the work that Albuquerque Community Safety has done is a benefit. Remember, we're diverting calls that were typically gone police. The police aren't taking those as many calls for those, and they're now diverting to us. So everyone sits on that AMRAC board as far as police sit on it. We sit on it, and we have those meetings every month.
Okay, so then both the question coming from Rosie was about exactly as well as just saying that both Albuquerque and Cleveland are under this consent decree, which, as I said, my understanding is this is basically a sort of enforced settlement where the police department has to do certain things to be in agreement with the settlement. And one of these was to create a mental health response advisory committee, the MRAC. And then the last bit, maybe you answered this, but she was wondering whether the MRAC in Albuquerque was involved with like sort of the nitty gritty aspects of even analyzing data and recommendations. And the way that I would think about this question was that I've looked at some point at the variance of police advisory boards, and some police advisory boards have very little that they can do, and some of them can do so much as they can like analyze data and make, not just reactive decisions, but proactive decisions where they say like, hey, we see these trends, like we are going to ask you guys to do this thing because we're seeing a concerning trend with this particular outcome. So how involved is this MRAC in making recommendations? Do they get to look at data and really make very specific recommendations as to how this is all working?
They do. So like I said, we have subcommittees in terms of like if we're popping up training or policy recommendations, they're able to provide feedback on that in terms of the data. Like they've done case studies. So they'll review case studies, let's just say for whatever it is, an enforcement piece took action, or there was a officer involved shooting, or some type of situation. They'll do case studies on that, and they'll discuss it during that MRAC meeting. And a part of that MRAC meeting, there is community members, and it's open to the public to come in and have those conversations. So in the past, we've had individuals who have family members experiencing mental health, and we've actually talked through the case with them before. So it's a very collaborative committee where there's it's represented by many members of our community, including our public safety agencies.
Thanks. That's really, really interesting. I had no idea. That's really cool. Thanks, Rosie, for that question. So next, Mike Jones asked, where did you take the violence interruption training, and how did you incorporate into the work that you do? So I know in both cases, the violence interruption is a sort of one particular group. I guess maybe the question is, that group that's doing violence interruption, where did they get trained? Like new people coming in, where would they get trained? And then maybe second question, how was that effort incorporated into the larger web of alternative response systems? And either one, please.
Yeah, so I think our violence intervention, we do internal training, but we also go out to trainings, whatever's offered within the community, right? Our violence intervention is in partnership with our police department. So because of we can go out right after a shooting occurs. So they're trying to, again, curb the cycles of violence. So that could be a retaliatory, potential escalation of violence. But so we are careful in our partnership with the police department with that specific violence prevention intervention to go at the appropriate time. So those are the conversations that we do shooting reviews weekly or bi-weekly on that. So the training is internal. I'll say this as a whole for ACS. When we started, we had like 4 weeks of training. We're now, we've evolved that over time. And now in January, we will go through a full 3-month academy where all of our employees go through that academy specific to their discipline. And that's where a lot of that violence intervention comes in. Again, our violence prevention is the majority makeup is peer specialists, so they have that lived experience in communicating with these populations.
So are community responders and violence interrupters and everybody else going through that same 3-month academy, or is there sort of components that are specialized trainings just for the violence interrupters, specialized for the community?
Exactly. So
Got it. Cool. Very
our
cool.
full 3 month is specific to all of our field responders, and then each one is incorporated as needed.
Wow. Awesome. Ryan, did you have thoughts on that?
We don't run a violence interrupter program. Our
Okay.
training, though, just to speak to it briefly, we have a little over a 2-month training where about 5 to 6 weeks of that is more, say, classroom-based, skill-based training, going through a curriculum, and then it's in field where they are practicing in field under a supervisor before they are cleared to operate. So we have that all to share. If folks are interested, we're happy to share what our curriculum or our training or our academy looks like. So
Awesome. Yeah,
yep.
it's really interesting to hear about how the training has evolved too. So another question from Ife Mbanefo. They ask, how have residents responded to the new system? It sounds like they were, at least some people were coming in with community feedback in the beginning, sort of talking about how they wanted to see it, but once it was there, how do people feel about it?
I'm happy to start real quick. So, I mean, in general, the reception we've gotten from the community has been very positive, not universally so, but we have very broad support. We have, residents who created like yard signs that they put up all over Durham around budget season, asking for the program to be funded 24/7. People often showing up in council meetings, expressing their support for the program. So we have a lot of broad support. The reason I say not universal is, as I was sharing with you right before this, one thing that we get some of, and I'm guessing Albuquerque does too, is some folks would prefer a law enforcement response to show up. So, someone is unsheltered, they are, sleeping outside, and they want maybe this person has been there 3 times before, and they want law enforcement to come and basically make the situation go away. We might show up multiple times and work. That person may move away, but the person may come back. And I think that can be frustrating. That frustration can be directed at the response instead of really at the underlying issues of our shelters are too small. We don't have enough permanent supportive housing, a bunch of other things that are contributing to it. And luckily, or I would say I'm appreciative of the support that we have from our elected officials and managers who understand that. So even if they're getting sometimes emails from downtown business owners, they understand what those concerns are really about and don't pin them to like an ineffective response.
Awesome.
I'll jump in.
Yeah.
We'll take a bit of a break. Sorry, guys. Jody Escobar here, the director of ACS. I think it's beautiful to kind of hear Ryan, because a lot of things are so in line and we're kind of just walking through this space at the same time. I think that we do have a really good response from the community. I think we have our first headquarters established here in the International District of Albuquerque, which is one of our most populated areas, which in turn means that it has the most calls for service for our 911 system. And so our location of our headquarters was strategic in the way that we wanted to be in the heart of the community, in the heart of kind of where we experience a lot of the homeless issues, and as well as a lot of the behavioral health calls. And so it was nice to just pop up in this area. And so the reception from this general area has been astounding, like to be able to have people just walk up to the area. We've had community events. We just had our trunk or treat that was far more bigger than we thought that it was. And so we're buying, hundreds and hundreds of bags of candy. And it was like, man, this is it. This is exactly what we were meant to do in this space that we were supposed to be in. And so I think in general, it's been a very great reception. And just to be transparent, as Ryan said, sometimes they do want a law enforcement response, and we're in this position that we will always hold the ground in enforcement, and we will have nothing to do with like the city is doing like issuing notices, hey, you guys have to move within this amount of time, and all these things that are coming down from the city, which understandably the things that they have to do. But as ACS's stance and what we were founded on was that we were already always going to be community first. And so we won't take part in any of like the enforcement side. And so sometimes people just want to say like, this guy has been in this location for this long and you guys need to move him. ACS doesn't move any of these people. Why do we even have ACS? No, they don't do anything. And it's like, well, there's just really so much more to that. And let's talk about the bigger problems, like as Ryan mentioned, the systematic breakdown. But I think that we're very similar in nature.
Thank you. That's really awesome to hear. And really interesting about the strategic location and how that shaped your experience. That's super cool. So I'm gonna do the two last questions, and then we'll cut it off. And so we have like about nine minutes for these next two questions. So one of the attendees, unnamed, asked, and this is a question very close to my heart. I forgot to say in the beginning that I'm an economist at Ohio State University, and I'm really interested, have done evaluation here in Columbus for the alternative forms of police response here. And I'm interested in looking at those sorts of evaluations across the US. So one anonymous attendee asked, what metrics are you using to assess the program's success? Are you looking at any long-term outcomes? And I would add to that, like, not only are you sort of tracking metrics, but are you really doing an actual evaluation, one that has a control group, one that you have data that's comparable across the group that gets treatment as well as the group that gets control group? So both of those questions to either of you guys.
I'll take a first stab.
Yeah.
I think it's really interesting because it's hard when people say, well, how do you measure success? And I would pause and think about some of the calls that I've heard from responders. I would pause and think about, if it was a family member and ACS responded and not a police officer or emergency, and we got them connected to the right resources. I would pause and say like, well, that one person that we helped was a success, right? And it's really hard, but I know because we're in the position to say, okay, here's city council and here are the numbers and this is what your budget does. And this is, we all know the system and how we have to defend that. I think that we can always lay our head on the amount of calls that we've diverted from the system. 911 as a whole, right? I think Walter mentioned earlier, over 80,000 calls of service. I think that's a successful way to lay our head at the pillow and at night, lay our head down at night and say, well, we responded to 80,000 calls of service at the right response at the right time. And that was diverted from another tax system, our police department and our fire department. And so I feel like that is something that is extremely successful. But I also think that we found success in the evolution of the programs. As Ryan was mentioning, hey, we're looking at these two other aspects and these two other avenues. But I think ACS has been really good at evolving to the needs of the community. And I feel like that is a success. And now we have the street outreach team and now the navigators and now the school-based program. And so like, if we weren't being successful, then they wouldn't say, okay, yeah, that's a good idea. You guys should do that too. And so I think just the expansion of ACS, I know that's not a metric that I can say, okay, we started with 2 teams and now we have 10. I can tell you that. We started with this many responders. And so I know that I think the calls for diversion is an easy way to say that is a success. I think we're diving deeper now into our data to say, okay, cool, what do those second touches look like instead of just the first initial reaction? And so I think that will be a good tell of kind of solving root problems as far as long term, as you mentioned, what are we going to do in the future, and also reducing the high volume. The repeat callers is exactly what Ryan was saying too, is, the people that are calling 911 multiple times a month, 30 times a month, can we have those calls subside a little bit too. And so those are all very tangible things that we're able to do with our data. I'll pause there.
Thanks. Ryan, have you guys looked at any of these metrics? What are you tracking?
Yeah. So one I just put in there, you have to go to the answer tab because the second I put it in, it kicked it over. So we collect a lot of data and we try to make a lot of it transparent to the public. So we have a public facing dashboard where you can learn a lot about our work. And we have a new dashboard we'll be rolling out soon that is just a whole bunch of different questions. You click on the question and it takes you to data that you can see the answer to that question as it and change the parameters and the dates and things like that. So we are really committed to trying to do our small part to build evidence. This is a new field. There's a bunch of questions about it, and we want to be a place where people can learn about this work and where we can learn for ourselves what's working and what's not. So part of that is being thoughtful about all the data that we're collecting. Part of it is partnering with external evaluators. So we have two external multi-year evaluations that are underway. One is funded by Robert Wood Johnson Foundation that folks at Duke University are leading, and it's going to be looking at community perspectives and experience with heart. It's going to be canvassing in areas where we're serving, surveys, both with folks who are receiving our work and with administrative, like both public safety and other folks who are doing the work or partnering with the work, to understand people's experiences over time with heart and also in comparison to their experiences with law enforcement. We have another evaluation funded by Arnold Ventures with RTI, and it is more of an overtime, more quantitative study. It will have a comparison group or a counterfactual, but I can't remember exactly how they're structuring that right now. I'm happy to put you in touch with them if you're interested in learning more about that. When we think about success, I would agree with Jody. I mean, one thing, I think part of this work was feeling like we over-rely on law enforcement and that there's an opportunity to send different types of responders. So I do think it is an important measure to say, these are the number of calls that used to go to law enforcement that don't, and to report, did anyone get injured or was anyone hurt? So we ask all of our responders after every single call to track, did you feel safe on this call? Did you feel you were the most appropriate response? Which is why we're able to report that on over 99% of calls to which we send responders, they feel safe. I think that's a really important data point for the field that shows that the boundaries that we have drawn for our non-police response seem, and there's a lot of evidence to support that it is safe and appropriate. We look at things like how many instances are we able to connect neighbors to the care that they need and want, and we're trying to deepen that understanding to understand if we're only able to do that 1 out of 5 times for the other 80% of times, why? And really understanding, is it about lack of resources, about ineligibility? Is it the neighbor did not want the particular service? There's a whole range of things that we really want to learn more about through care navigation. We look at comparative differences. So one thing we're trying to take advantage of is we still have, in the same day, calls that are eligible. We know every call eligible for us by the way that calls come into 911, which we didn't go into. So we know when a call gets a police response that was eligible for a non-police response, and when a call, the same type of coded call, gets a heart response. And so we're trying to look at the things that both of those groups measure, and this is a limitation because we track a lot of things that law enforcement doesn't, to understand comparatively what are we seeing. And in general, we see lower arrest rates. In general, we see different transportation rates. So our responders are more likely to take folks to the 24/7 recovery and response center as opposed to the hospital. So there, those types of things, those can be high level measures. Long term, it's hard to see some things because data sharing, some of those things are very difficult to understand what happens after you make a connection to care. But yes, there's a lot of work going and a lot of interesting questions left to still be figured out.
Thanks. Yeah, one of the questions, one of the points that I've realized doing this evaluation work in Columbus and then reading similar papers that have done cutting edge evaluations, like really only come in that last couple of years. There's a big problem in you just don't have the same data for your control. Like the people that are going to police are not getting the same data as the people collected as the people who are going to an alternative response program. And neither program is collecting long-term things, right? Like, in fact, very rarely do you have the ability to, for instance, link up with Social Security numbers, which would allow you to see people's health claims in, years. I think that's really where the cutting edge of this should go, is being able to link up people on both people who got all sorts of responses with, at the very least, their subsequent claims data for health outcomes. So I think we're going to end up going over a tiny bit because we started a little bit late, but I'm going to ask this one last question. I saw another one pop in. I'm not going to ask it, Kathleen, because we're so over, but I'm sure somebody will try to answer it live. But I do want to get to Bill Vedra's question because he's been asking for a while. Bill Vedra has the 911 center here in Cincinnati, and he wants to know whether the panelists see this decision to go, or you guys both mentioned that you went in-house with your clinicians and you think that was good, but what were the pros and cons of that? So try to keep it brief, but to the extent that there were cons, what were those cons, and why did you think it was a good decision overall? And why don't you start, Ryan, since you're unmuted?
I've got 4 points. So, because I saw that question. So, in no particular order, one, I think that in doing this work and doing something new, doing it in-house makes it you're a little more nimble. You're able to pivot. If there are things you want to change, it's easier to change that when you're controlling all aspects of the program. When it's a contractual relationship, that can just be a little more difficult. Second point, access to data, especially for the city. The city may want to know certain things about the program. Sometimes when that sits outside of the city, it can be harder or take time for the city to learn the things that it wants. Sometimes just privacy and data like that might make it harder for city leadership to understand how a program's working. Three, I think, and that to me is a really important reason, I think that there is greater sustainability in developing the program in-house, and that when you place it outside through a contractual relationship, it can be more susceptible to disruption. And there have been examples of cities that have worked with a third-party partner. Something goes wrong with that third-party partnership, and now the city wants to end that contract. Now what happens, because that other organization has developed the capacity and know how to do the work. They have the staff. It's not an easy thing for the city to then pivot that work in-house or to another provider. And that could be a real disruption. So if a city is starting small, I favor like learning how to do it in-house, because I think that longer term, that is just a more sustainable path. And then the final thing is, I think that there are some potential benefits to culture. These are potential, but if you want to shape other public safety culture by adding in something like this, to me, it feels like there is a different standing if the work is outsourced to let's say a behavioral health provider. I think that other public safety responders may view that differently than oh, these folks are like us. They're hired, they're city employees like us. I just think there's something there that has some impact over time, and I can't really qualify that. I will say one of the trade-offs is if you're working with, say, your health system and you're contracting with them, they're going to have access to for some people you're working with, they'll have access to a wider array of data about how that person is interacting with those systems. That's things we've been able to figure out how to get some of, but not the same level of. And so I do think that's a trade-off just to name. But for us, we feel that for Durham, it was the right decision to do it in-house, and we haven't regretted it for a moment.
And for Albuquerque, I would just say ditto, to keep it short, because that's pretty much those are the same reasons as us. I think the big piece to focus on for us was sustainability. So when we created the positions, they were what we consider unclassified positions. So they're at-will positions, but we moved within a year to classify those positions. So now they're classified positions, and now we're unionized. So the big piece of it for us was actually sustainability. Through it, all of our positions for our responded are general fund moneyed positions. I think if I had to say a con, it would be anyone that works in government knows how long things take sometimes. So hiring and stuff, it takes a while for us, where that might not be a case for outside contractor agencies. But overall, we also feel the same. Is like it was our best route for sustainability to do it in-house.
Another thing that strikes me just to add is hearing from both of you guys about the curriculum development. It seems like you had a process where you developed this curriculum that you feel really good about and is specifically addressing the particular things that you want your people to know, which is not possible if you're out housing it. All right, thank you so much. That was really, really awesome. I'm gonna hand it over to Pete from Policy Matters to finish off. Thanks a lot, everybody.
Yeah, thank you, Leah, and thank you both, all of you for doing this work with us and being here today. So I am going to, and also Walter and Jody and Ryan, if you do want to answer that last question about I see Leah, you put something in too, but if you have anything more you can put in the chat or in the Q&A, that'd be great. And also there was a request for curriculum, so maybe we'll follow up and we'll try to get that out if you all can share that. I am going to call quickly on Jordan Ballinger from Disability Rights Ohio for a quick update about a group that he's convening.
Thanks, Pete. It's been great to be here and listening to all of the incredible work going on around the country. Hopefully, we can replicate something at a more system statewide level here in Ohio, which is why I'm going to speak very briefly, which is DRO is looking to convene a coalition of stakeholders who are interested in working together in the next state biennial budget, which begins in January, February of next year, to look at a statewide pilot program with targeted investments into certain communities for community response programs. So this would go beyond kind of our triple C's in large cities here in Ohio and focus kind of around the state for these investments and get more state funding. We're hoping to gather as many groups and individuals and stakeholders as possible. So if you are interested, please feel free to reach out to me directly. That's Jay Ballinger at disabilityrightsohio.org. You can also go to our website to find my email, or you can go through Pete to get my email as well. But we're really looking to convene stakeholders here in the next couple of months to begin ramping up that budget process.
Great. Thank you, Jordan. That's super helpful. And I'm going to put in a quick plug before we end. Madeline Cobb from March for Our Lives was going to do a quick presentation about the People's Response Act. So I'm sharing my screen right now. This is work that's happening. It started at the federal level where there was a proposal to do a People's Response Act. We would create a Division of Community Safety in the Department of Health and Human Services, and then that would run grants to do different approaches statewide. So now March for Our Lives and Madeline, who's based in Ohio but is working nationally, is doing a lot of work around this different states, both red and blue states, different kind of settings to do something similar at the state legislative level, right? So, and this is really interesting for us in Ohio. The idea of, again, creating a Division of Community Safety within the state health department, do grant programs to fund community-led organizations, advancing community safety in different ways. And some of that is driven by the violence interruption work that they're doing, but all of this is, if you were on our September call with the Ohio organizations, we included everything from the mental behavior health work in Cincinnati and Shaker Heights to the mediation work in Dayton and the violence interruption work in Cleveland. So this is very encouraging. I think it'll wrap in really well with work that Jordan mentioned. And finally, do stay tuned. Emily Cole was also not able to be here from OFUPAC, and we're looking at how do we pull together people for advocacy at the State House. And again, that's all wrapped up into what we're talking about with Jordan Ballinger and the work to create this statewide group. So that is all I'm going to do. I'm going to stop sharing. And I just want to thank everybody so much for being here, for staying as long as you have, and for putting up with the tech issues at the very beginning. Again, Policy Matters, OFU PAC, Columbus Safety Collective, and Disability Rights Ohio, we thank you very much for being here. Thank you to Walter, Jody, and Ryan for this amazing discussion, and of course to Leah for the excellent facilitation, and the rest of you for the questions and your interest in this. We'll be following up soon. As soon as we can get the recording up online on the Policy Matters website, we'll share that out, and other information and materials we get from the panelists, we'll share that out as well. Thank you all.
Thank you, everybody.